Welcome to the Pancreatic Cancer Action Network's webinar, Communicating with Your Healthcare Team. My name is Allison Mayoral, and I am a Patient Central Manager for the organization. At the Pancreatic Cancer Action Network, our goal is to provide you with better resources so that you can make informed decisions. A Patient Central associate can provide you with personalized information free of charge on topics such as treatment options and pancreatic cancer specialists. Contact Patient Central at 877-QPANCAN or email patientcentral@pancan.org. The webinar is scheduled for 60 minutes and includes a presentation followed by a question and answer session, time permitting. Questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Barbara Biedrzycki is an oncology nurse practitioner for the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins and a clinical research associate for the Johns Hopkins University School of Medicine. Her main research interests are decision-making, symptom assessment and management, quality of life, and advanced care planning. She is nationally certified both as an advanced oncology nurse practitioner and as an adult primary care nurse practitioner. She works with the Pancreas Multidisciplinary Clinic and provides outpatient care to individuals with pancreatic cancer. Barbara, I will turn the presentation over to you.
Thank you. Before we get started, I'd like to thank the Pancreatic Cancer Action Network, PanCAN, for all of their work for and on behalf of people diagnosed with pancreas cancer. PanCAN's mission of supporting patients, advancing pancreas cancer research, and creating hope is truly valued by patients, family, and clinicians. I'm deeply honored to be part of PanCAN's educational webinar series. Today I'm going to share with you information to help you get the most out of your healthcare appointments. As an oncology nurse practitioner, patients and their families have taught me so much about what they want and what they really need from their meetings with their healthcare team. There are times when there is great two-way communication, and other times when the information exchange could have been better for either the patient, the family, or the healthcare provider. And even sometimes communication fails for all involved. During this webinar, we will talk about effective communication, a meaningful clinic visit agenda, and decision-making. There could be a variety of people on your healthcare team. Sometimes a healthcare provider may have multiple roles, and other times each person on the healthcare team may have a specific, unique role. The number of people on your healthcare team may be dependent on the size of the practice and the facility where you'll be receiving care, or on whether you are receiving oncology care in an academic, community, or private cancer center, or at an oncologist's solo or group practice. We'll review the various people who may be on your healthcare team. But please do not think your care is inadequate if you don't have a lot of people on your team. When you have a smaller team, your healthcare team members may serve multiple functions and roles. The size of your healthcare team does not matter. What matters is that you receive the quality oncology care that you deserve. Whether there are many of us or just a few people on your healthcare team, you are always the main person on the team. It is essential that both you and the team are clear on the goals of care, each of our roles and our responsibilities. We all have a shared identity, being your healthcare team, and we are all committed to providing optimal health care to meet your individual needs. Team unity may either be quite obvious or it could be more subtle. Healthcare teams may project different team connection vibes simply because people are different. If you know that you are the star of the team, let your team know. They'll appreciate the feedback. If you're not feeling the team spirit and desire the togetherness that teams have, speak up and let your team know. They too will appreciate this feedback. The first oncology care provider that you meet on your arrival for an appointment may be the clinical assistant, medical assistant, or medical technician. The title provided reflects the person's training and responsibilities. They may measure your weight, height, and vital signs. They may ask you some questions or ask you to complete a symptom survey. Some have phlebotomy skills and may take blood samples from you. There are three main pancreas cancer treatment disciplines: medical, surgical, and radiation. Medical doctors, MDs, who have special training in cancer are called oncologists. Although all are medical doctors as their primary physician training, they only specialize within one discipline. For example, the radiation oncologist will not be performing surgery, and the surgical oncologist will not be administering radiation. Oncology nurses have different titles and roles, including registered nurse, nurse navigator, and nurse practitioner. Oncology nurses may be working within a specific discipline, chemotherapy, surgery, or radiation, or they may be providing or assisting with cancer treatment administration, performing triage, conducting research, assessing symptoms, providing education, evaluating for healthcare services, or providing home care services. We'll talk more about the role of the oncology navigator soon. The oncology nurse practitioner is a registered nurse who achieved additional academic education, either through a master or doctorate degree, and healthcare training through an NP program and passed a national qualifying examination. Laws vary among the states to legally define the nurse practitioner's scope of practice. That is what we can and cannot do. Some states have restrictive practice for nurse practitioners, meaning that they are not able to prescribe all medications. Some states require a supervisory or collaborative practice agreement. That is, a physician and nurse practitioner jointly submit to a regulatory body like the State Board of Nursing an agreement as to what the nurse practitioner can and cannot do. These agreements may limit the nurse practitioner's practice more than the state law allows, but cannot exceed the state's law's scope of practice. In Maryland, my home state, in 2015, nurse practitioners became independent providers and do not require physician supervision or collaboration. Most of us in oncology do work directly with our physician colleagues and not totally independent practices, even though the law allows it. Nurses have the option of demonstrating their proficiency through oncology nursing certification. To become oncology certified, a nurse or nurse practitioner needs to meet specific criteria for time worked in oncology, as well as passing a challenging national exam. There's also your extended team. Just like an extended family, sometimes we may want to see some of our extended healthcare team members more frequently than others. Your extended team may include a dietitian, financial advisor, counselor, gastroenterologist, home care nurse, interventional radiologist, mental health therapist, pain management specialist, and a palliative care team. Please note that the extended team's titles are listed alphabetically. Their placement on the list is not intended to imply a hierarchy of value to you. PanCan has created a fact sheet titled Members of Your Healthcare Team that provides additional information for your reference. On the fact sheet, PanCan differentiates the title and qualifications of the dietitian and nutritionist. The fact sheet states, in quotes, all dietitians are nutritionists, but not every nutritionist is a dietitian. They go on further to tell us that since the title of nutritionist is not regulated, anyone could be a nutritionist without any training. Because we are interested in nutrition, we could call ourselves nutritionists. A registered dietitian is specially trained in nutrition, participated in the clinical internship, and passed a national examination. And then there's even more people who could be on your team, including a pharmacist, phlebotomist, psychiatrist, psychologist, physical therapist, physician's assistant, receptionist, rehabilitation specialist, social worker, and scheduler. Again, all listed alphabetically. There may be additional clinicians that are not on the list. When a person is referred for counseling, it could be with any number of clinicians who provide mental health services, including a chaplain, mental health therapist, psychiatrist, psychiatric nurse practitioner, or psychologist. They each have different training and offer a variety of services. From this group of mental health professionals, only a psychiatrist or a psychiatric nurse practitioner may prescribe medications. If you want to meet any of these clinicians, ask someone on your primary oncology team, that would be your oncologist, nurse, navigator, or nurse practitioner. They will be able to tell you if this person is easily accessible or help you determine who can best meet your needs. And then there are the people who are behind the scenes that you never meet. They are also actively working on your team so that you may receive optimal oncology care. The behind the scenes people includes administrators, billing personnel, information technicians, insurance specialists, laboratory technicians, managers, medical record specialists, phone triage nurses, pathologists, radiologists, and many more people. They are the infrastructure of your healthcare team. The newest additions to the oncology healthcare team are the navigators. The navigator may be a layperson who is someone without a healthcare license, or a nurse navigator who could be a registered nurse or a nurse practitioner. The roles of navigators may vary greatly, as there are different job descriptions and several organizations who have defined the roles. According to the Academy of Oncology Nurses and Patient Navigators, some of the services that the patient navigator provides is being a broker between the patient and the healthcare system, and they help with logistics, structural, and social needs. The nurse navigator is more clinically focused and identifies and removes barriers to care and may be your central point of contact. If you join the cancer clinical trial, you will have a second team called the clinical research team. Some of you will be working directly with the oncologist, research nurse, and nurse practitioner on the clinical research team, and even more behind-the-scenes people like data managers, financial managers, regulatory specialists, research lab technicians, and sponsors. They're the people who pay for the research to be done. There are also regulatory teams called the Institutional Review Board, called the IRB, and the Institutional Biosafety Committee, IBC, who are looking out for you. The IRB's main purpose is to protect the rights and welfare of research participants. The IBC focuses on reviewing, monitoring, and reducing the risk associated with potentially hazardous experiments. You have all these people who are involved directly or indirectly with you. Those who run your team you may see regularly, and there are faces you may never see who are essential to your health care. When you think about your oncology team, how many people are there on your team, not counting your family members? The question is, approximately how many people are on your oncology team? Select A for less than 3, B for 3 to 5, C for 6 to 8, and D for 9 or more. With so many people in your oncology team, it may be challenging to determine who is managing your oncology care, or you may consider it to be who is your go-to person? Who do you call or email when you have a question or concern? And this may or may not be your oncologist. The oncologist is in charge, even though you may not be directly communicating with the oncologist every time. Be assured that the nurses, nurse practitioners, and physician's assistants are discussing your care with your oncologist as needed. It's important to remember that you are the person who is ultimately in charge. You may be greeted with the customary, "How are you today?" Sometimes people share a detailed response with the first person they see about their main concern. For example, you're greeted by the clinical or medical assistant who takes your vital signs and wait with a friendly, "How are you today?" And you share your main healthcare concern in great detail while the assistant attentively nods his or her head. Shoo, glad that's over, right? It felt good to get that out of the way. Now you can relax. While you may emotionally feel better after expressing your concerns, you will need to repeat it again. Do not assume that the assistant shares that information with your nurse practitioner, oncologist, or physician's assistant. You may need to tell the healthcare provider who sees you behind closed door. This really does happen. Sometimes people think that everything they tell one person on the clinical team is disseminated among the entire team and recorded in the medical record for us all to know about. It usually does not happen that way. Even if it did, it would be beneficial to discuss the information again once you were in the office. We want to talk with you about how you're feeling. If we did not discuss a health concern that you told someone else before you met with us in the office, it's because we didn't know about it. Please always repeat your health concern if it's not addressed by your oncology care providers. While there is some variation about the actual years and the age ranges for generational labeling based on who is doing the categorizing, such as the United States Census Bureau or other organizations, generally speaking, there are 5 generations. The greatest generation was born 1920 or earlier, the silent generation born before 1946. These 2 generations tend to like formalities and keeping everything stable and working just fine as it has in the past. The baby boomers born between 1946 and 1964 tend to respect authority more so than other younger generations. They equate work with self-worth and self-fulfillment. The Generation Xers were born between 1965 and 77, and they grew up in a world of instability and the decline of America's power. They seek a balance of work and life, and they appreciate instant feedback. Due to their youthful experiences with video games. The generation years for millennials born after 1978 accept a non-nuclear family and consider nothing sacred. They appreciate comfort and technology and teamwork. They are multitaskers and want flexibility. I do realize that I'm stereotyping the generations. However, these examples may provide some insight into the basis for different communication styles and why we have some unique communication challenges across the generation. How does this generation data impact our healthcare? Well, consider the United States labor force where most of the workers are Generation Xers and millennials, with the number of millennials steadily rising. The U.S. labor force data may be reflective of our healthcare team and help us understand the value and communication styles of generations different than our own. Sometimes we think we are expressing ourselves so clearly, and others have a different interpretation of what we're trying to say. I love this cartoon. As the girl expresses herself artistically as a beautiful flower, her 11 student colleagues are perceiving a different interpretation. The flower girl is so pleased with her portrayal as she thinks everyone is getting the same message, but they're not. There are 12 different views of the same action. Note that all the students in this cartoon are in the same generation. Just imagine the other interpretations that would be possible if parents and grandparents were interpreting the artistic floral expression too. Consider this model from Brody on effective communication. There are 2 people, a sender and a receiver. Let's assume that the sender is the patient. The patient expresses feelings of, I feel great. They're raising their hand in joy. They're giving nonverbal message and a verbal message to the receiver, the clinician, and the clinician has the perceived message, perceived meaning. But they may also be asking for some feedback because they know that the person has just went through a very challenging treatment and they want to know more about how they're really feeling. The person is very optimistic. They're trying to express themselves in an optimal way. So the clinician sends a message back to the sender, you know, what's really going on? Are you really feeling as good as you're looking and how you're saying? So we're trying to get a balance between the sender's reality and the receiver's reality. Of course, there could be some noise involved here. That noise could be, the environment. It could be other family members trying to intervene. So it's a lot that goes into having effective communication. But the main point that I'm trying to make here is that communication needs to be two-way. It just can't be one person telling another person. You have to make sure that you're understanding the message, and they call that meta-communication, when the communication goes back and forth, and you include both verbal and nonverbal messages. Philip Clampett provides a communication model for us to consider for effective communication. When clinicians either provide too much information and hope that something sticks, or the other extreme and withhold information and therefore withhold the power for decision making, they are not communicating the best they can. Tell and sell means that you receive information on the key issues and then the providers preferences, or recommendations. You may not be receiving all the information you need at this level to make an informed decision. Identify and reply means that the communication is not proactive and is more defensive. The best approach to communication, according to Clampett's model, is to share information and listen and repeat, using the two-way communication model. If we are not communicating well, a lot of things could go wrong. Ineffective communication can cause confusion, distress, frustration, and loss of confidence in many situations, not only in cancer communication. If communication is not effective during your visit, you may not understand the recommendations you have. You might be uncertain about the true therapeutic intent of the treatment that's recommended, and you may not be clear about the diagnosis and its meaning. Ineffective cancer communication also harms society as it slows down the progress of cancer research. Health literacy can be impacted by language. Some people have limited English proficiency. Others may experience language barriers not only related to accents or education, but due to the fact that we are speaking a different language, the language we sometimes call medical jargon. As a novice registered nurse, I experienced a language barrier when a physician came into a patient's hospital room where I was providing AM care. Yes, I'm dating myself now when I use the term AM care. That is, or rather was, the morning bath that was provided by the nurse. The physician clearly stated that his patient's disease was, in quotes, idiopathic. The physician provided no additional information about the idiopathic diagnosis. He then asked if the patient had any questions. There were none, and he left the room. The patient, who had previously been quite talkative with me, was now quiet, and so was I. I was hoping that she would not ask what idiopathic meant, as I surely did not know at the time. Later, I looked the word up in the hospital's Merck manual. Yes, that was even before Googling the internet was available, and learned what it meant, that the disease had no known cause. When I shared this information with the patient, she cried, as she thanked me for explaining this to her, as she thought the doctor was implying that she was an idiot, as only idiots had her illness. This was some miscommunication and health literacy deficit. Health literacy can be thought of on different levels. Functional literacy refers to the ability to read and write. Communication or interactive literacy refers to using functional, cognitive, and social skills to actively participate in life by applying information to changing circumstances. Critical literacy enables us to analyze information to have greater control over life's events. According to the World Health Organization, health literacy represents the cognitive and social skills which determine the motivation and ability of individuals to gain access to, understand, and use information in ways which promote and maintain good health. This knowledge management cognitive pyramid illustrates from the United States Army that in order to achieve wisdom and have minimal decision risk, we need to have a shared understanding of the plan. We can achieve this by processing data into information that can then be changed to knowledge. By knowing what and knowing how to do something, we can achieve the ability to understand why we're doing something. If data is not processed, we are at the greatest risk for decision making. In my research of 197 patients with advanced pancreas or colorectal cancer who were invited to participate in a cancer clinical trial, 88% of them perceived that they had adequate information to make an informed decision about clinical research participation. And yet, only 35% of them actually achieved a passing score of 70% on the knowledge test of basic information about cancer research participation. 72% indicated that they had a perceived understanding to make a decision. What this data demonstrates is that even when patients think they have enough information and understanding to make a decision about cancer clinical research participation, at least according to this research study, most did not achieve a passing score in the knowledge test. For an initial healthcare visit or when important options are being discussed, I usually advise the more ears the better. But there are two qualifiers. Only if the patient wants other people there, and also that the patient chooses who will be with them, who will join them. Bring someone with you who makes you feel comfortable. Please note that I did not say the more mouths the better. While it's not mandatory that your guests keep quiet, they should only be asking questions with your permission. Hopefully this will be discussed before the visit. You may want to ask all the questions, or you may want your guests to ask all the questions, or you may share the responsibility for asking questions. Sometimes the ground rules on who will dominate the discussion and ask questions are not discussed and can be a sensitive topic. Some patients have been silent with their eyes gazed downward as their guests take over the visit with their questioning, asking things that are priority questions for them, but not necessarily for the benefit of the patient. And then there have been times when an argument ensued during the visit regarding questioning rights. Just like this illustration has a variety of mouth ears, people are different in which ears they want to wear, if any. If you want to bring someone with you who makes you laugh, or someone who has a magical way of helping you understand and cope, or a family member who has the traditional support for you, it's okay. Caution is urged to not bring too many ears. The room is likely to feel uncomfortably crowded if there are too many people in the exam room or consultation room. You may want to have someone call in on the speakerphone to help with communication. It's a good idea to assign someone the responsibility of writing down notes. Some clinicians have mixed feelings about having the visit recorded. If you want to record a discussion, please ask your clinician if it's okay to record the visit. I'm not sure why some people try to hide their cell phones so that they can secretly record you. When a hidden recorder is discovered, it may hinder the development of the therapeutic patient-clinician relationship. I recommend that you and your guest talk about what you heard at the visit later. Some people choose to do it at the ride home, and others wait a day or two later. It can be quite stressful for you and your guests during the healthcare visits. It's possible that the intent of a healthcare discussion was misinterpreted. Consider the cartoon with the flower girl. There could be several renditions of various interpretations. If after discussing the content of the visit with your guest, there is still some ambiguity, contact your clinician for clarification. It's always best to ask, and even ask again, than to be misinformed. Discussing pancreas cancer and options can be very stressful. We understand that, and we don't mind answering repeated questions. Research has been done that demonstrated that some people are not physically able to retain information after they receive distressing news. One 40-some-year-old man explained to me that after the physician told him he had pancreas cancer, all he heard in his mind was cancer, 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 even though the physician was trying to transmit valuable information about treatment options. He really did not recall anything that the physician said after declaring the diagnosis, other than the word cancer that kept echoing in his head. Instead of explaining to the clinician that he did not retain any of the important information and asking for the information to be provided again, he sought a second opinion with us after he could think more clearly about his new diagnosis. The author of this thought-provoking statement is unknown. The biggest problem with communications is that we don't listen in order to understand. We listen to reply. Sometimes patients are so focused on providing quick and accurate responses to our questioning that they're not focusing on the message we're trying to deliver. While we really appreciate your dedication to provide us with information, please remember that our goal is to help you understand information about cancer, options, and how it impacts your life. Here are 5 tips that were published in Conquer magazine, a free publication that is not cancer site specific. These 5 tips are very relevant for your first visit and also for subsequent visits. Ensure that your medical records have arrived before you do. Sometimes you may not be able to get records, images, or other reports to us in advance, and you might need to bring them with you. While it's ideal to have time to review your data before you arrive, receiving the data in real time is okay sometimes. Come prepared with an agenda for the meeting. What do you want to talk about? Are there specific questions that you want answered today? And also, you should know that the clinicians, they have their own agenda. We have things that we want to share with you, specific things for each visit that you come to, but we also want to address your needs. Beware of hearsay, which refers to not only the advice others are telling you over the phone, in person, or electronically, information that you're receiving passively, but also the information that you're receiving actively. As you know, you cannot believe everything you read or hear. If you are inclined to research the internet for pancreas cancer information, please use reliable sources such as PanCan, the National Cancer Institute, or academic cancer centers, to name a few. Your support system may be fluid, meaning that you may bring a different person with you to each visit. Instead of having too many people join you in the exam or consultation room, consider dividing the group up so that they alternate when they accompany you to your oncology visit. Also, by accepting offers to help, even though you may feel a little uncomfortable doing so, you're building your support system. People love being helpful. Some say that people are helpful because of the joy they receive from helping others. So help them to be happy. Accept their support. It's important to have realistic expectations of your oncology visit. There have been times when people come in with several pages of questions. That's okay, but they need to realize that we can only discuss a limited amount. If you need more time, schedule another appointment. We do realize how important your questions are, and we do want to answer your questions. Please temper your expectations of what can be accomplished during one single visit. It may be appropriate to ask about costs of cancer treatments, especially if your insurance does not cover the treatment. It's reasonable to ask if the recommended treatment is covered by your insurance. Don't assume that it is. Some treatments can be extraordinarily high in cost to you. You have a limited amount of time for your visit. By prioritizing your agenda prior to your visit, you will be able to discuss the items that are most important to you and save less important items for the next visit. Be prepared for the visit not only with your agenda, but also by considering how you will respond to your clinician's possible responses. For example, if you're having insomnia, you can't sleep, and you want to talk about this to your clinician, prior to your visit, think if you would accept a sleeping medication if offered. Being prepared means thinking about your tentative reactions, options, and follow-up questions. When you're not clear on what your clinician is saying, ask them to repeat the information in different words. Try not to nod your head yes to recommendations when your mind is thinking, no way, or cannot focus on the discussion. You are not going to offend your clinician with questions or challenges to their recommendations. Remember to use effective two-way communication. So there's the 5 W's and 1 H. That is, who will be giving the treatment, when will it start, frequency, when will it end, how long will each treatment be, what exactly will the treatment be, where will it be delivered, why is this treatment recommended, what's the goals of the therapy, how will the treatment be given, include side effects. These are some questions that you may want to ask your clinician. Before you leave the clinician's office, I suggest that you and your clinician determine a plan. The plan doesn't need to be that solid to say like you're scheduling a start date for treatment, but rather it could be to review information about your recommended treatment and return next week to discuss further and possibly decide on the treatment option. Before you leave, you also want to find out how you are to communicate with your clinician, by phone, by web portal, electronic chart. Do you call the clinician directly, or is there someone on the team responsible for answering questions, scheduling appointments, and triaging your needs? Ask your clinician what is a side effect or concern that needs to be reported right away, and what can wait until next week's visit. My advice is, when in doubt, check it out. meaning that don't keep unanswered important questions that are worrying you. Contact your contact person for answers. Some teams may have an oncology nurse available to answer your questions. Contact your clinician when needed, or tell you to go to the nearest emergency department or call 911. You also want to obtain emergency contact information. Is there someone available 24 hours a day? Never put off making a call when you are urgently concerned, no matter what time or day it is. Do not leave emergency messages on an answer machine or submit them through email or the electronic record. Be sure you talk with someone directly, or if a message service is used, how long will it be before you will get a reply? When should you call 911? What if you go to the ER or admitted to a hospital? Who do you contact? These are all very important questions that need answering. The first time I heard this term, value-added visits, was from a patient with metastatic pancreas cancer who explained his joy when he had a value-added visit. He said at each visit he expects to be evaluated and treated as this is the purpose of his oncology visits. However, there were times when he felt that he received a bonus. To him, a bonus was when we talked about his feelings of living with cancer, helping him to understand his prognosis, and helping him to cope. While the evaluate and treat visit was meeting his expectations for oncology care, he was even more satisfied with the value-added visits. It's time for another question, and this time, if you would please respond to, is it the doctor's job to make medical decisions? For yes, click A. For no, click B. In medical decision making, there are several items that are very important to consider. Clinical guidelines, the provider's professional experiences in pancreas cancer management, the provider's preferences that may or may not be similar to your preferences for treatment, and patient engagement. How much is the provider including you with the decision making? The Cochrane organization provides systematic reviews of research data and literature to advance science. There are different levels of research and reviews. Efficacy test if something works, and that's the first rung on the ladder. Effectiveness test if something benefits patient outcomes. And cost effectiveness research determines the cost-benefit analysis, and they also explore efficiency, that is, how much benefit at what cost. Early research initially tests if a new treatment works, and then later how well it works and how it impacts patient outcomes. If you are concerned about treatment options, you want to know how effective the treatment is. If you are joining a cancer clinical trial, ask if the research is focusing on efficacy or effectiveness. I'm just looking at the responses now about is it the doctor's job to make medical decisions. 67% said no, 33% said yes. The NCCN is the National Comprehensive Cancer Network. They provide clinicians with guidelines based on the best research evidence available for pancreas cancer. As knowledge from basic and clinical research continues to evolve our understanding of and treatment options for pancreas cancer, the clinical guidelines are updated frequently by a group of pancreas cancer experts. The latest clinical guideline available was just released on February 24th, 2017. There is also a 94-page clinical guide for patients available at the NCCN website. Chapter 6 is devoted to making treatment decisions and includes information on treatment plans, your role in planning, and getting a second opinion. PanCan also has valuable written education fact sheets on being your own advocate and considering a second opinion, as well as many other informational books that I highly recommend. In order for people to be actively engaged in communication, there should be adequate health literacy in an understandable language. We need to be culture and value sensitive, and we need to remove barriers to communication as best that we can. We strive to provide patient-centered care. That is, to be respectful of and responsive to individual preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. And this is as defined by the Institute of Medicine. In order to make a decision, you need options. Sometimes people don't feel they have options, especially with pancreas cancer, but they do. You can decide chemotherapy, yes or no. Which regimen, A or B? Clinical trial, yes or no. These are just a couple of examples of when you have options and need to make a decision. 197 patients with advanced pancreas or colorectal cancer who were offered participation in the cancer clinical trial at Johns Hopkins were invited to participate in my survey research. The results identified many variables that collectively go into decision-making for a cancer clinical trial. These 13 items include cancer stage, symptom burden, age, educational level, race, sex, hope, quality of life, trust in the healthcare system, trust in health professionals, patient preferences for research control, perceived risk and benefits, and adequacy of research information. Collectively, this model leads to clinical trial participation and research decision satisfaction. This data demonstrates the value of the conceptual research decision-making model. So let's talk more about decision-making. There are three main types of decision-making: dependent or passive, in which someone else makes the decision for you without your input; shared or interactive, in which you learn about and decide what is best for you based on two-way communication with others, perhaps two-way communication with your clinicians, family, friends, other patients, etc. Independent or active decision-making refers to when you make decisions without input or influence from others. You may seek out information, but that does not impact your decision. The majority of people, that is 83% who participated in my survey research, preferred shared decision-making for their decision to participate or not participate in a cancer clinical trial. While there had previously been research on treatment decision-making, this research revealed the previously unknown value of shared decision-making preferences in cancer clinical trial decisions. 13% of the group preferred independent decision-making for the cancer clinical trial decision. The preference for decision-making was not related to the patient satisfaction or cancer clinical trial participation. This research was conducted at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins in Baltimore, well known for pancreas cancer care and research. Therefore, these results may not be generalizable to other facilities or patient groups. No one in my research indicated that they preferred reliant or passive decision-making. These results do not imply that there is anything wrong with allowing someone to make the decision for you. It's just reflective of the responses from research participants in this study. Some people want to entrust their decision-making to the person who they believe knows what is best for them. I hear this a lot. How can I make a decision? You're the one with the education and experience. I want you to tell me what to do, what is best for me. By involving the person, if they're willing, with decision-making, it does not mean that we're placing the decision responsibility squarely only on the patient's shoulders. We are there also to shoulder that responsibility with you. It does not mean that it does mean that we want you to have as much information and understanding of the diagnosis and treatment option and how the options for decision may impact your life as you want to know, and that's important. There have been some times when patients clearly do not want much information about pancreas cancer and oncology care. I do tend to offer the opportunity to discuss cancer care at several visits to these folks who were previously not interested, but I don't push them into complying with my beliefs in the value of information and shared decision-making. People have different values and different perspectives for decision-making. As clinicians, it's our responsibility to determine your preference for decision-making and respect it. So there's a definition for shared decision-making, and it is an approach where clinicians and patients share the best available evidence when faced with the task of decision-making, and where patients are supported to consider options to achieve informed preferences and responsibilities. Our personal values guide our decision-making. What is most important to you may not be as important to me, and vice versa. We may not actively think about our personal values often. Our personal values are inherent in our personality. It makes you the person you are. Sometimes in facilitating decision-making with patients, we can learn a lot about your personal values, even identify virtues that you were previously not obvious of. Your healthcare team may be able to help you put words into your personal values and guide you to see how your personal values focus your decisions. Many times people have shared that having a pancreas cancer diagnosis has helped them to be more engaged in life and to realize what is really important to them. Roy E. Disney, the son and nephew of the Walt Disney founders Roy O. and Walt, who led the Disney Corporation for many years, said, "When your values are clear to you, making decisions becomes easier." I would like to leave today with Nelson Mandela's quote, "May your choices reflect your hopes, not your fears." And PanCan's vision to wage hope. Thank you for allowing me to share my thoughts with you today.
Thank you, Barbara. So we have some time for some questions. The first question is, what should I do if I feel like I cannot communicate with my doctor?
If you feel that you cannot communicate with your doctor, one question I would ask is if you have someone else to bring along with you who might help with facilitating communication. There could be a multitude of reasons why the communication is not working well, not being as effective as it could be. I think first it would be best to bring someone with you who could facilitate communication. You could also ask if there is another person on your healthcare team who could join you with your visit with your oncologist to help identify perhaps any communication barriers and help to address them and find a strategy to work it out. Sometimes addressing your communication concerns directly with your oncologist, if you feel comfortable with that, may help to solve the problem. There's a variety of ways that you could address this, and I commend you for your efforts to improve communication with your provider.
Thank you. After I receive my diagnosis, what role does the gastroenterologist play on my healthcare team?
The gastroenterologist may be someone who you were first encountered. You might have had a longer relationship with your gastroenterologist with having routine testing done, screening done in the past. The gastroenterologist is still definitely part of your healthcare team. Usually the oncologist would not recommend routine visits unless the gastroenterologist would want to see you, perhaps maybe every so often for just a follow-up visit. However, if there was a need for a procedure or need advice specifically about a medication or something, the oncologist may ask you to return to your gastroenterologist for follow-up. Oh, the other thing is that please make sure that your oncologist shares your medical records with the gastroenterologist. That's very important. I'm assuming that you want your gastroenterologist to continue to be involved, and you never know when you're going to need that person's services again. So keeping them informed is a good way to continue to have that person in your team.
Great, thank you. We have another question about what if I'm not happy with my current doctor? Should I seek a second opinion from another doctor at the same hospital, or should I go somewhere else?
The reason that the person's not happy with their current oncologist can vary. It could be because of communication issues. It could be because they're not, they don't think that they're getting a good recommendation for treatment options. I'm not sure what the reason is why they're not happy with their current oncologist. I know from my practice, we don't encourage people to switch oncologists, because when you are at a facility that has the same continuity of care and has usually a multidisciplinary group is going to kind of be recommending the same therapy. You're not going to get a different treatment option by going to another oncologist in the same facility. If you wanted to get a second opinion, that is something that's definitely always encouraged. No one on your oncology team is going to be offended by you seeking a second opinion. At Hopkins, we do a lot of second opinions, and sometimes people will come in for a second opinion, will return back to their oncologist to receive the care because that's closer to their home. Sometimes you might not be quite satisfied with your local oncologist because they're not giving you the optimal treatment, but by working with oncologists at a cancer center, you may be able to return closer to home and receive treatment and actually be more satisfied with your local oncologist care because of the interaction from your second opinion.
Great, thank you. Who should I contact for concerns about discomfort and or side effects? That is something that hopefully you will be able to determine on your first visit to find out, who's your contact person. As I mentioned in the presentation, there may be a number of people. There could be a triage nurse, there could be a navigator, there could be other people on the team that would be your main contact person if you're having side effects or symptoms. But as mentioned, all this information gets relayed to your oncologist. So by talking with someone else about your side effects and symptoms, please don't feel that your oncologist is not being aware of those. But hopefully the first visit you can, that's a very important question for you to ask about who is my contact person, how do I reach them, what's the best way to communicate, and also for emergencies and 24-hour service. Thank you, and we have time for one more question. How can my family be a part of the care team?
Your family can be part of your healthcare team by being involved. Sometimes family members don't live in the area where the patient lives or where they're receiving their oncology care. And when family members are distant from us, they can still be involved on the team by communicating through phone. When you have an office visit, this is something that we do a lot. If someone has a cell phone, or we can use the hospital's phone and put it on speakerphone to include other people to listen in on the discussions, sometimes to ask questions with the patient's permission, of course. But that's an important way to involve family members in your healthcare team. Also, you can share with them what is happening with your care. You can discuss with them how you're feeling and how you're coping about that. That makes them an integral part of it. I think it's important to build your support network, and that also is definitely your family as well as others who may be interested in being there for you and being part of your team.
Thank you. We would like to thank Barbara for her presentation. The PowerPoint slides and the recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted. Your patience is appreciated. A survey will pop up once you leave the session today. Please take a moment to share your feedback. If you have questions or would like more information about specialists in your area, please contact Patient Central at 877-2-PANCAN and ask to speak with an associate. This concludes the webinar today. Thank you.